Wonderful. And all right. And if you'll just keep monitoring that and welcoming people in, that would be great. So, all right, let's go ahead and get started. Good evening, everyone. And on behalf of the Lamb Foundation, it is my pleasure to welcome you to our Circle of Hope Transplant Support Program webinar. I recognize some familiar faces in the crowd and see many new faces as well. I am so glad you all could join us. We have a fantastic and full agenda for you this evening. My name is Cindy Beasley, and I am the Director of Education and Advocacy for the Lamb Foundation. I also oversee our Circle of Hope Transplant Support Program. I will be your moderator this evening. In addition, Lisa McMillan Pascal, a 9-year transplant recipient and a participant in our Circle of Hope program, will be joining us as our group session moderator after the presentation. So, before we get started, I would like to take a moment to recognize and thank our generous sponsor, the National Disease Research Interchange, or NDRI. For those of you unfamiliar with them, the NDRI is a not-for-profit organization with over 40 years of experience in supporting the advancement of biomedical research through providing human organs and tissues from a diverse pool of donors. Their partnership with the Lamb Foundation and Lamb patients has pushed forward the science of Lamb through procurement of tissue at the time of transplant. We appreciate their ongoing support in our research efforts and our educational programs. So, as I mentioned, we have a full evening ahead. We will begin with a presentation from the medical director of our Circle of Hope program, Dr. Dan Dilling, followed by a Q&A session with him. We will then hear Lisa McMillan Pascal's story of her journey through the transplant process. And finally, we will move into a patient and family group discussion. I encourage you to stay logged on for this opportunity to connect with fellow Lamb community members from around the globe. So, just a couple of quick housekeeping items. Microphones will be muted and the chat box disabled throughout Dr. Dilling's presentation. At the conclusion of the presentation, we will open the chat box where you can put in questions there. Also, we are recording the presentation portion of this evening's session. If you do not wish to be visible on the recording, please take a moment now to turn off your camera. We will not be recording the group session. So, now it is my pleasure to introduce our speaker this evening, Dr. Dan Dilling. Just a moment here. Dr. Dilling is a professor of medicine at the Loyola University Chicago Stritch School of Medicine and is the medical director of the lung transplantation program at Loyola. He oversees an advanced lung disease program where patients with pulmonary fibrosis, as well as several other advanced or rare lung diseases, are under the care of a multidisciplinary team. He is a member of the board of directors for the International Society for Heart and Lung Transplantation. In 2010, he established the Lamb Clinic at Loyola, where he continues to serve as director and now cares for well over 100 patients with Lamb. Dr. Dilling is also a board member of the Lamb Foundation and serves as medical director for the Foundation's Circle of Hope Transplant Support Program. Outside of medicine, he enjoys golf, live music, and spending time with his family and his very important 3-year-old Bernie Doodle, Ringo, which I believe he has a picture of here eventually. So, Dr. Dilling, thank you for joining us this evening. I will now turn this over to you.
Thank you. Let me bring up my first slide here. It's my pleasure and my privilege to be here with you all today. So thank you for the invitation and for all of you for your participation and attention. So it's great to be here. So indeed, I enjoy this role because it lets me wear 2 of my hats at the same time, which is a pulmonologist involved in lung transplantation, as well as someone who takes care of rare lung diseases and especially Lamb. So glad to be here. So the thing that I was asked to talk about with y'all was about the new system of allocation for donor organs. This is for the United States only. but it's called the continuous distribution and lung composite allocation score, or the CAS system. So I'll be talking you through it today and sort of a little compare and contrast with the previous system and how we hope that it may benefit the population as a whole, but also I think maybe population of LAM patients. So as was already recognized, the NDRI is an organization that helps collect tissue for researchers across the country, in fact, around the world, from and keeps it in a biobank freezer, and it can be produced for research proposals in different labs around the world. And the only way tissue can exist in this biobank is by donation. And the one important motivation for the Circle of Hope program is not only the education and support of the patients, but the support of research endeavors, including collection of tissue. So the program's been very successful at helping to facilitate collection of tissue, including fresh tissue, which is kind of especially important for some certain labs at the time of transplant, where we know someone who has advanced lung disease, LAM specifically, might be, which is not a very common reason to have a transplant, where that tissue can be donated. And we've been very successful at setting up those donations ahead of time, and then retrieving the tissue and getting it sent out to folks that need it pretty efficiently. And you can see actually how rare lung transplants for LAM are. This is United States data from the from UNOS, or the United Network for Organ Sharing. Number of transplants per year, going back about 13 years here. It's consistently below 10 per year. So that's how rare this is. There are something like 3,000 lung transplants per year in the United States. So think about that percentage there. It's 1% or less. In fact, the program has been successful at gaining tissue from a majority of these transplants with the permission and, in fact, the wishes of those that are donating the tissue, the women having the lung transplants. So I wanted to make you guys all aware of the program and the importance of this tissue. And if any of you are on wait lists or seeking placement on a wait list of a lung transplant somewhere, be aware that this program exists to help get your tissue into the hands of researchers. It's tissue that you obviously don't need anymore, and if you're willing to have it utilized in this way to help seek treatments and the cure for LAM, then thank you. So one other introductory point here is that lung transplant survival in LAM is among the best, or in fact, it is the best with regards to comparison to other kinds of lung disease that have lung transplants. It's far better. We talk about something called the median survival, which is the length of time after which half of the recipients of a treatment or who have a disease or who undergo a surgery of some sort, the median survival is the number of years or months, sometimes, after which half the people that have the procedure have passed away. And if you look at the blue line, that's all comers to lung transplant, and you can see that that line crosses 50%, or the median survival, somewhere between 5 and 6 years after the transplant. Naturally, that means that many patients, half of them, in fact, are going to have a length of survival well beyond 5.5 years, but that indeed is the number we refer to as the median survival. Some work that was done a couple of years ago, looking at the database from UNOS again. So this is United States lung transplants over a period of time of 2003 to 2017, looked at how well patients with LAM have survived compared to these other diseases. And you can see that it's well beyond the median survival for all comers. In fact, it's 12 years and beyond. So this is remarkable, and I think it is part of the reason that the new system of allocation will benefit patients with LAM to help them be paired with a donor. So as we're bringing in a patient to the clinic with the idea of whether or not they are somebody that should be placed on a wait list and undergo a transplant procedure, we really want to think about a concept called the transplant window. So what this means is that we want to have somebody on the list and perform the transplant in a period of time when they're neither too early, meaning not sick enough in their lung disease, where you might put them at this extra risk for complications and even lethal complications of a transplant. If it's too early, it just doesn't make sense. But also where you don't want to wait too long so that it's not too late, where maybe there won't be time to get a donor or go through the procedure testing for getting onto the list, or maybe waiting too long means that the person gets too weak or sick in other ways to be able to have the wherewithal to get through the recovery period and onto a successful transplant after transplant survival time. So that it doesn't mean that we shouldn't see the patients really early. I mean, I actually believe that it's important to be seen in a transplant center well before it's time to go on the list, because that gives you lots of time to grow familiar with that team. It gives you time to improve some features of your case that might be undesirable or let's say less than perfect, meaning maybe your support team, your family team around you needs to get better or be identified even. Maybe you're just going to educate yourself. Maybe there's things like obesity or substance abuse or nutrition issues that you need to work on, and that gives you time to understand what the expectations are going to be. So seeing the transplant team too early is actually a good thing. Going on the list too early is not a good thing. So that's where I'm talking about the window, but seeing the team before the window opens is a good thing, is the bottom line. And so that's something to think about as you're considering the idea of looking at a transplant as a possibility. So it's interesting to think about the incredible logistics kind of organization that's needed to achieve a transplant. This is for somebody who's already on the wait list and is seeking their transplant and trying to be paired with it. So if you think about someone up here in the upper left corner, this is a patient on the wait list, and they're on a lot of oxygen, perhaps keeping themselves healthy through exercise and other things, hoping for those lungs to come. And indeed, we have every transplant program around the country, and there are about 70 or so hospitals in the United States that perform lung transplants, and maybe about 150 around the world. So we all have a list of patients that are on this wait list waiting for lungs to come. One day, and it's of course in the middle of the night most of the time, I'm not sure why, but it is, that the phone rings for at our hospital, and there's a donor offer somewhere. And I'll explain in slides to come how this gets identified as a donor for this particular person. So there's an organ procurement organization. My local one here in north part of Illinois is called Gift of Hope, and there are many of them around the country, carving up the United States, where these organ procurement organizations under the umbrella of UNOS, or the United Network of Organ Sharing, help to not only identify potential donors, but once that donor is identified, they're helping to keep the keep the brain dead person alive through ventilator care and fluids and antibiotics and other things in an ICU somewhere. So Gift of Hope is helping to maintain the donor in a way that they continue to be a viable donor, and begin to find hospitals, perhaps around the country, that are going to have someone who can accept the liver, someone who can accept the kidneys, someone who can accept the lungs, someone who can accept the heart, perhaps the pancreas, perhaps even small bowel in some cases, or some other body parts might be available for donation. So Gift of Hope or a similar organ procurement organization is helping to do all that. The organ offer comes and we get the phone call at our hospital, and we learn a lot about that donor. We find out their story, we find out their health history to the degree it's known. We get to see all kinds of tests that are happening, including a chest x-ray and a CT scan of the chest, lots of blood test results and infection testing, all sorts of things. Even there's a bronchoscopy. We get to learn what happened, what the inside of the lungs look like. There's a really extraordinary amount of information that is brought to us, again, always in the middle of the night. And we have basically a half an hour to distill all this information and decide if we want to accept that organ for that particular recipient, and then perhaps we say yes. So the check mark of yes, we accept the organ. Then our team, our nurse team, actually organizes a whole bunch of stuff, not only in our hospital, admitting the recipient to the hospital if they're at home, and starting to organize the operating room and the team in the operating room and getting everybody called in the middle of the night, but even organizing cars and airplanes, because our surgeon from one of our surgeons is going to go with the nurse in a car to the airport. They're going to fly to some other city perhaps, and then take a car from there to the hospital, along with a team that might be coming for the liver, a team that might be coming for the heart, et cetera, et cetera. There's a whole big organization of processes that have to come together. And so everybody comes to the organ procurement, and there's a sort of very organized series of surgeries that go in a special order to be able to safely maintain each of these organs as the whole procedure is happening. There might be some organs that are going to go into an organ preservation system. So either lungs can do this some of the time, kidneys do this a lot, where they go into a machine that allows them to be pumped with a blood or a blood substitute and air or whatever, and hearts can do this too. And that might be one way of improving the transportation of the organs, or sometimes they're put into a cooler, and it really is just an igloo cooler of some sort, and with a special amount of packaging to make sure that they're not going to be damaged in transport, but several hours perhaps just on ice. Again, organizing cars and airplanes to get back to our hospital, where then the surgeon knife is initiating the procedure. In fact, the the removal of the organs from our recipient is usually happening well before the lungs are even in the air coming back, so that it's perfectly timed, so that when the transplant, when the organs enter into the operating room, they're basically ready to go in. The first lung at least has been removed, and the space is there for the organ to be, the first organ transplant to happen, and then the second one, if it's a 2-lung operation, happens after that. So you can see, I think, through this slide, all of the tremendous amount of work that is necessary to get all this organized and make it all go sort of seamlessly. And of course, it doesn't always go seamlessly. Sometimes there are hitches in the logistics of these cars and airplanes that are coming from all these different places, and delays get put into the whole system. And just because you think that your transplant is going to happen tomorrow at 4 a.m. doesn't always mean that it will happen then, because delays happen. A lot of details here that are all happening at once. So a new system came into place last year at the behest of leadership through Health and Human Services to try to make as fair as possible the allocation and matching of organs to recipients. There had been different systems going back in the United States. The last big change was in 2005, where something called the lung allocation system, or LAS, got put into place. Before that, it was really just waiting in line, almost like first come, first serve, which was not fair because some people's diseases are moving faster than others, or some people get onto the list only late in their disease state. And so the lung allocation system in 2005 changed the system into one where it was more dynamic, and someone who was very sick could go basically to the front of the line and be at the top of the list for the next set of organs. But there were still some problems with the lung allocation system, partly because of how much it favored locality or place that a person was and how far they were from the donor hospital. It had a big preference for trying to keep things close. It also had a big preference for trying to sometimes match to recipients who were the sickest of the sick, maybe even to the point that they were so sick that they weren't necessarily going to have the best outcomes, but it was matched to how sick you were more than it was matched to how well you were going to do, how likely you were to have a good outcome. And that was thought of as somewhat unfair and nonsensical. So this is why this continuous distribution model came into effect over the past year. And it was really carefully designed by a lot of, it wasn't just the government imposing, it was the government asked for a new system, and then really smart people that were in the transplant field sort of helped design, and computer models helped to create what was thought to be the most fair and systematic and most logical way of trying to address some of the problems with the lung allocation system. So the lungs, by the way, are the first organ to go into this new system. It is expected in the next few years that liver and heart and kidney transplant are also going to get into a new system of continuous distribution, or a CAS type of system, but lungs are first. And this just happened in March or April of this year. And so it's designed to allow multiple factors that contribute to a successful transplant to be considered. So the goals are prioritize the sickest candidates first. So that still is a priority to make sure that the sickest patients have a strong sort of advantage in the system, because if you're the most likely person to die next and you're a good candidate for a transplant, you're the perfect person. But we also, like I said, wanted to make sure that the system was going to do a better job of improving the long-term survival and helping those people that had the best long-term likelihood of survival. Also, we want to increase transplant possibilities for patients who might have been harder to match. So there's some people that have antibodies that make them less likely to have a good match with certain donors. And so if you're one of those people that have built up these antibodies, perhaps through pregnancies actually, or sometimes through blood transfusions or other means, that where you become what we say sensitized to other individuals in the population. So in the past, these people just had less likelihood of getting transplanted, but under the new system, there was set up a way to try and give them a little extra priority in those donors that they had a good match with. And also, we wanted to increase transplant opportunities for people that might be in special populations. So, people that might be pediatric, under 18, or people that had in the past given their own organs out of just magnanimous attitudes to other people, perhaps to their loved ones or sometimes even to strangers. And this would normally be a kidney that they've donated, sometimes a partial liver transplant. And so, it used to be that these circles around a particular will prioritize uh, recipients that were in those circles. So around 250, a 500 circle, and a 1,000 circle were where the first offers would go to. And if you were many states away, you wouldn't really have the same access to a particular donor, even if you were very, very sick. And that was always meant to try and reduce some of the time that organs would be in a cooler. That was meant to try and reduce some of the extreme costs of organizing all these airplanes to go everywhere, and that. So it was, but it was a little too rigid. There was also ABO matching things. So it used to be that A recipients would only go to A donors would only go to A recipients, and B only to B, and O to O, to try and keep that a little bit fair. But there were, of course, people with AB who could receive any organ, and they might be the sickest person in the world, and they wouldn't have the same access to some of those O organs because they were first going to people that were in the O blood group, and so that was a little bit cumbersome for the matching process. And then the last thing, and I alluded to this earlier, is that there was a 2-to-1 priority weight put on how sick you were against how well you might be able to survive. So the 1-year survival, it was really weighted perhaps a little too heavily on how sick you were, at the expense of maybe how likely you are as a recipient to have a long-term benefit from the procedure. In fact, they were only measuring long-term benefit in the LAS system for how likely you were to make it to 1 year. So, I mean, it's a lot harder to make it to 10 years or 5 years than it is to make it to 1 year, of course. So people would argue that 1 year shouldn't be the goal. We should be trying to aim towards longer term benefits. All right, so the new composite allocation score, or CAS, was developed, which still took into effect medical urgency, or orange, how sick you are, and it still took into effect how likely you are to survive, long-term benefit, although 5 years instead of 1 year. But it brought in these other factors, and we'll see them all in the slides that follow. So patient biology, like blood type and those antibodies, comes into play, and patient access, so certain special populations, and placement efficiency. So distance still is going to come into play, but just in a different way and a bit more fair way than it used to. So medical urgency, you get, you don't have to worry about the number of points, but you get points for urgency and you get points for likelihood of survival. Again, survival now pegged to likelihood of surviving 5 years. And they're equally weighted. So 25 points for one and 25 points for the other, not double weighted for how sick you are anymore. The biology stuff is like that, antibodies, the blood type, and height. So because you can imagine that a really short person can't receive very tall lungs, they won't fit, whereas a tall or medium-sized person could still receive small lungs. It's not ideal, but they fit. And so short people were disadvantaged under the previous system. And so there's now some points you get for being short. There's some points you get for having these antibodies, and there's points you get for having certain blood types where you're restricted from others. And so blood type is still included. It's just included in a, let's say, a more equitable way. And then special needs, these are people that are pediatric or people that have previously given their organs. They get a little extra priority with some extra points. And then there's still some points given for efficiency, like how much, whether you have to fly or not, and also kind of how far away you are. You still get some points for it, but it's not locked into that circle. You can overcome it by being, having points accumulated from all these different places. And so for each patient, there's kind of these points that arrive, and as opposed to the old system where it was here, the lung allocation system, it's now a larger composite of different sub-scores, different points you get for different things. And you actually get a score when you go on the list, but your full score, as you might imagine, because of distance and antibodies and blood type and everything, your full score is individualized for each donor. So for each donor, no matter where they are and what their blood type is, you might have a different full score, and your place on the list compared to other people on the list is going to be different based upon that particular donor. So it's much more dynamic than the old system. I really explained this already, so I'll skip it. So some things that go into the score are things that might declare how sick you are, what your urgency is, some things that might declare how likely you are to survive long term. So right heart catheterization, whether you have something called pulmonary hypertension, makes you a sicker person. How much oxygen you are on also. Whether your 6-minute walk distance is kind of a surrogate for how strong you are or how well you can go through rehab and recover. So that gives you some information about your likelihood of longer term survival. The creatinine or kidney function probably tells something about both of those things. Same thing with the bilirubin, kind of a liver function. Arterial blood gas tells us something about how sick you are as well. The diagnosis, whether you have LAM, whether you have pulmonary fibrosis, whether you have COPD, there are different long-term outcomes with each of those if you have a transplant. And I've already shown you how the long-term outcome in LAM is among the best, it is the best of all the different reasons to have a lung transplant. So that gets baked into that score. And so obviously, if you're doing some logic here, you're seeing that the diagnosis of LAM is advantaged through this new system. In a similar way, younger age, is going to make you more likely to be able to have a long-term survival through any kind of procedure, any kind of illness, any kind of surgery. And so people of younger age are going to have a better predicted long-term survival in the system. And the majority of, let's say, the average age of patients with LAM who need a lung transplant is much lower than the average age of patients with COPD or pulmonary fibrosis that need a transplant. And so you can kind of see how age is also going to advantage patients with LAM for being able to get a high priority score and be matched with a donor. And so we have here, sorry for the small print, but this is like really what our computer portal looks like. And this is a whole bunch of the patient information, whether it's their test results or their age or their blood type and all kinds of things. And we have a nurse that when someone goes on the list, they plug in all kinds of information into all these different places. And at the end of all of that plugging and chugging of information, that CAS subscore is spit out. And that score comes with from all the different points that I've kind of described to you already. And some of the points, as I said, don't come until they don't get allocated to a particular person until a donor is in the works. So, and then at that point, you see how far they are away, what the blood type is, and these things. The average subscore, this meaning before there's any donors, just sort of the basics of you, is likely to be between 15 and 25. And a really high subscore is in the 30s. That's really high. Most of the time, a really high one is in the mid 20s. It's pretty rare to see. As one example, is a patient who is didn't have LAM, but Group A means obstructive disease, and that's the same category, one of the same basic category that LAM goes into as COPD. And so this was a 56-year-old, so that's kind of on the young side for a transplant recipient. And under the lung allocation system, this is the day before the system changed. The lung allocation score was 36. And by the way, it was about, on average, about double. They all cut in half, basically. So the LAS, if it was 36, they usually did come down to about 18. And so in this patient, it came down to 18.9. Something like basically how sick they were was calculated by the algorithm as 330 days. It was still 330 days, but now it was weighted 1-to-1 with survival. So it wasn't given the same amount of weight. And 1 year survival prediction was 320 days after the transplant. The 5-year survival here was 1,313 days. And so it was a different kind of point allocation. There were some points given for blood type. There were some points given for antibodies here, and there were some points given for height. So this person's allocation score actually became a bit higher compared to his or her peers than it was under the old system. This is what a computer screenshot looks like of the match run, or like the match list for a particular donor. So I have no idea where this donor was, but this was a donor of the donor that maybe that we were less likely to be concerned about in our system. So anyway, you can kind of see how a match list looks there. So that's everything I wanted to show you. I wanted to make sure to leave some time for questions. And someone was asking earlier what it meant that I was the companion of Ringo. Ringo is my Bernedoodle. He's actually 4 years old now. You can see we had him with a special little Loyola bandana back a few weeks ago. He's a big guy. He's about 90 pounds, so his head's as big as mine. But I hope this was helpful, and I also hope it generated a lot of questions that we can talk about here in the moments to come.
Yes.
Full disclosure, I have to drop off right at the hour, so we have some time to talk. But I have to go take some kids to volleyball and pick up some other kids from a different volleyball, so I have to leave right at the hour.
All right, we'll do our best to get as many questions in as we can then. Thank you so much. At this time, we're going to go ahead and open the chat box. So feel free to type in your questions there, and we'll pick them up, and I will read them to Dr. Dilling. I do have some questions that were submitted to us in advance, so we'll start with those. The first one is, when should a LAM patient start thinking about getting on a lung transplant list? Are there some indicators that are unique to LAM patients? Any preparations that need to be done for us as in a specific population?
So as I described before, I think it's a good idea to see the transplant center when it's too early. hopefully your transplant center will have good insight into you being too early, as well as what you see as insight into that. But here are some guideposts, and none of these things are an absolute, kind of have to, but I'll give you kind of guideposts of when you maybe should start to see a transplant center, and then I'll give you different guideposts on maybe when I think they ought to be looking at trying to get you on the list. So things are starting to get bad if you're needing oxygen, especially if you're needing oxygen at a pretty decent amount, especially if you're needing oxygen just to sit still. I would say if you're developing pulmonary hypertension or high blood pressure in your lungs, it's another sign that things are getting worse. If your FEV1 is heading down, like sort of, well, if your FEV1 is below, say, 40 or 45% and heading down, that's a sign that you're getting worse and you're headed in that direction. And then maybe if your carbon dioxide level is building up. There might be some other people who are having lots and lots of pneumothoraces, and they have bad lung function underneath it, and that might be kind of an earlier reason to see the transplant center. Now, who needs to go on the list is a little different. As I described, hopefully in an understandable way. But I don't think someone should go on the list until they're really unlikely to live another couple of years. And that probably means they're on a heavy amount of oxygen. It probably means that their FEV1 is down in the low 20s or lower. It probably means that they have developed some degree of pulmonary hypertension. They probably need oxygen just to sit still. They might have life-altering kind of disease, extremely life-limiting disease.
Sure.
So in other words, I have patients who are in my care who are on oxygen, who have some limitations in function, who've had a pneumothorax in the past, whose FEV1 might be in the mid-20s. And they're not on the transplant list. So it's not any one of those things that means you have to go on the list, but it's sort of a combination of them in a way that makes your likelihood of dying of your disease in the next couple of years to be pretty high.
Well, to that point,
I'll even say this: I've seen patients who've been cared for elsewhere, where they've been told they need a transplant, and I don't think they do. I think it's still too early. So there obviously is some degree of honest judgment there that is going to go on, and two smart and experienced doctors in different places may have some differing opinions about the timing of all this. I'll grant all that, but you really need to be pretty sick, because what I always say about transplant is you're trading one disease for another. Immunosuppression and the complications and the issues that come with immunosuppression, and as you saw in the likelihood of survival, these complications can take a toll to the degree that it may not be worth it to make a trade until you really are facing something that's towards the end.
Sure. Well, that's a great segue into our next question, because what you're speaking to also is the uniqueness of LAM, right, in terms of the evaluative process. And one of our questions was, will a pulmonologist with not much experience with LAM be able to determine what the right time is, right? Many of our LAM patients don't live near a LAM clinic, but is it better for them to go ahead and see a LAM specialist, or can they be confident in a regular pulmonologist?
Yeah. Well, that's sort of there might be two ways of answering that question. One separate from transplant altogether, just is it better to be seen in a LAM clinic than in a let's say a general pulmonary office? And I think there are advantages to it. There are ways in which there's insight into when to start sirolimus, or how to track the disease, or what things to monitor, and how to talk about the disease, and how to deal with a pneumothorax. I think there are advantages to being seen in a LAM clinic, even if it's once, or even if it's only every couple of years or something, and maybe there might be ways to create a coordinated effort between your local pulmonologist and a lamb clinic if that's feasible. I
Right.
understand there may be logistics and costs that make it impossible, and I don't know how to overcome those exactly, but it's ideal, I think, to be in a lamb clinic. Now, separate, I thought the question was going to be about whether seeing a transplant center that has experience in seeing lamb is important. And I'd say there's some advantage there to that, but there's also probably bigger advantage to being, if you're going to have a transplant, to being close to home. Having a transplant far away or in another state or even several hours of driving away creates a lot of logistical challenges after the transplant, because it's not like you have surgery and go home and that's it. You have a lifelong tie to that transplant center afterwards, and all of the testing and return visits and all the management that has to happen there makes it really hard. So it's not always possible to have it both ways, where you have a transplant center that has specific lamb experience and all that, but there, it would be ideal, but it's
Mhm.
not always possible.
Yeah, no, those are great considerations. And these next two questions really have to do with sirolimus in the role of transplanting. One says, my hospital will let me stay on sirolimus until the call. What is the lifespan of the drug in the system? And then does lamb grow back in those transplanted lungs? And then should they start taking sirolimus after they've healed from transplant? So can you help us understand a little bit about sirolimus and how it plays into transplant?
Yeah, we've talked about this in some previous sessions, but obviously there's different audiences every time.
Mhm.
So Sirolimus or everolimus are two drugs that are in the class we call mTOR inhibitors. They're both useful in slowing the disease progression and are standard things that we use in treating lamb, especially when it's moderate or severe, including people that are at the point of needing a lung transplant. The trouble is that these drugs can have bad effects on wound healing, and so there actually were some really bad situations that happened back about 20 years ago when we were using sirolimus and everolimus right after the transplant, and this wasn't lamb. It was just using it as an immunosuppressant in general, and the healing of the airway fell apart, and people died. So it's a really worrisome, or it's a question that has a lot of uh, opinion around it and a lot of strong opinion and energy around it because of those experiences of 20 years ago. And so sirolimus lasts in your system longer than everolimus. It might last in your system for some days after you've taken your last pill. And so there are some transplant centers that won't allow you to be on sirolimus while you're on the wait list, because when you get the call, it's not like you get to wait a week before your transplant. It's going to happen the next day or two. So with that said, there's some places that are nervous about that, but there have been a lot of patients transplanted under an arrangement where they're on the drug up until the call, and then they stop taking it, knowing that the levels and the exposure of the drug is going to be dropping over the first couple of days of your transplant. And we're not seeing a lot of problems with airway healing or other kinds of healing. So we believe it's probably safe to continue the drug while on the wait list, um, recognizing there's going to be a lot of debate around that issue. Whether
Right.
it's sirolimus or everolimus is a different question. Everolimus lasts shorter in your system. Everolimus lasts longer in your system. So some places might say, we'll let you stay on it, but it's got to be everolimus instead of sirolimus while you're on the wait list. But both have been used, and we're not seeing a signal of big problems afterwards. Now,
Okay.
whether to use the drugs after the transplant, it was the second part of that question.
Mm-hmm.
Um, so LAM is one of a couple of diseases that has been sometimes recognized to come back after transplant in the transplanted lungs. The good news is that it almost never is back to the point that it's causing severe disease or creating big problems. It's like kind of microscopic or very small level. And so I think the approach of maybe using standard immunosuppression and switching to sirolimus or everolimus only if stuff starts to happen or if it's recognized to be LAM recurring, maybe it's okay to have that approach. Some centers will try and get one of those two drugs back into your medication list earlier rather than later, knowing that it might recur. But I think the recurrence of LAM is probably only a small concern after the transplant.
All right, thank you. I'm going to pull this question from the chat box, and I recognize we probably have more questions than we have time right now. So for those of you who have submitted questions, we will do our best to get these answered to you and get back in touch with you personally to get answers to you. But here is one. Are there some factors that completely disqualify you from being eligible for a transplant? For example, having another type of cancer, completed treatment for that cancer. Do you have to be at the 5-year survival window for that cancer? So what's some interplay then?
Yeah. There's some things that are sort of absolute contraindications to having a transplant. So, and these aren't meant to be punitive. They're meant to be helpful. Actually, you wouldn't want to go through a transplant only to have a terrible death of some complication or recurrence of the cancer or something. So cancer is one thing that depends a little bit on what kind of cancer, where it was, what stage it was, and things. But cancers are generally put on a 5-year window before they're of being cured before their person's eligible. It might, like I said, it might depend on what kind of cancer and the details of it. Obesity and undernutrition or other things, current smoking or other substance abuse might be things that would make you unlikely to be a candidate. Sometimes extreme age, kind of much older age might be a worry. There might be other health issues, bad heart, bad kidneys, and things that might also put you out of consideration for a transplant.
I'm guessing so because there are several questions that have some specific things that are unique to a person. My assumption in that is that that's all going to go into that serious score that you showed us, that first part of the pie, right? In evaluating how sick are you and how likely are you to survive. All of those factors would go in and be evaluated by the transplant center itself.
Well, there's kind of two phases to this. There's the testing phase where you see the transplant center and they kind of think you might be eligible for a transplant. They put you through a whole lot of tests and make sure that there aren't any hidden problems. And then a group at that transplant center will look at all of your test results, your whole case, and sometimes they might decide that you shouldn't even go on the list because you're unlikely to have a good outcome, and we're more likely to harm you than hurt you than help you with a transplant. So some people won't go on the list with that sort of assessment having happened. And then the second part is once you go on the list, yes, there are those factors of age and health and test results and that go into the formula that gives you a score that helps match you with donors in a way that I showed you already.
Right. Yes. Thank you. And then this was a question from someone overseas. Is it possible for foreign patients to get a lung transplant in the U.S.?
The short answer is yes, but it's a very complicated process. So it is possible. Transplant centers are allowed to put people that are foreign nationals on their list to a certain degree per year. There's, of course, immigration issues that may come into play. It's not like you can have a surgery and go home. So you have to be in the United States near your transplant center, usually at a minimum of a year afterwards, and for the whole time waiting as well. So it's well more than a year. And insurance is going to be complicated. It's not going to, foreign insurance and stuff is not going to. So the ones that tend to happen, unfortunately, are either very wealthy people that can afford all of the costs, or a foreign government that might pay for some of their citizens, or like an oil company or something that they work for. Like, these are some of the examples. This is not something our hospital does very often, but in those hospitals where it happens, it tends to be these privileged individuals, or maybe a country that doesn't have lung transplant, and they set up a program with X hospital to, send their patients there.
Sure. Do you know, has the number of LAMIs requiring lung transplant increased since COVID? Have we seen any relationship between COVID and
I don't think
transplant
there's a
numbers?
relationship. A little bit in the last couple of years, I would say, and they had gone way down after we started using sirolimus. And so I would say that we probably slowed a lot of people's disease that was, they would have had their transplant years ago, and we slowed their disease, and now they still come to the point of needing a transplant just later than they used to. So they're later than they would have before. So I think we're just sort of seeing some late bloomers, if you want to call it that. Yeah.
But not necessarily COVID.
Well, I don't think COVID had a specific impact on it.
Right. Okay.
LAM.
Well, we're getting close to your time to go get those kids. So I just wanted to thank you for this informative presentation. So I know as a LAM patient that transplantation is often in the back, and for many of us in the front of our minds, right? So it's encouraging to see how the science has progressed in terms of our understanding of survival rates for women with LAM, as well as the overall access to lungs. So thank you for the information and really the hope that you provided for us this evening. Again, for those of you who had questions that we didn't get to, I will be sure to connect with Dr. Dilling and get answers for you here as soon as we can. So we want to sincerely thank you for your support of the LAM community on many levels, and wish for you enjoyment for the rest of this evening. And so if you can, give a round of applause to Dr. Dilling. How we do that online, but we certainly appreciate your time. So thank you so much.
Thank you. And I just want to emphasize that I think the vast majority of patients with LAM are never going to do a lung transplant. So I know it's something that kind of is very front of mind sometimes, especially when you're new in your diagnosis, but it's very unlikely to be necessary, especially if you're not severe at the outset of when your disease is recognized. But if you do need a transplant, you're one of the people that's going to have one of the best likelihoods of survival just because of the type of disease that you have. Right. And lastly, this new system has created a terrific advantage for getting matched with donors that didn't exist before, or it was not as quite the advantage it was before. And I think we're all seeing more quickly transplants happening for patients with LAM on the wait list, even if they are very few in the first place.
Yeah, it's really great. It's just another piece of that hope, right, that we have as women with LAM. So thank you.
Sirolimus and everolimus are really good at treating this disease, thank goodness. Of course, we need better things going forward.
All right. Well, thank you so much.
All right. You're welcome. Thank you. Bye, everybody. Have a great discussion in the second hour.
Thank you. All right. Well, at this point in time, put this on. There we go. I would like to introduce Lisa McMillan Pascal. Lisa received a double lung transplant in 2014 at the University of California, San Francisco, and I have asked her to share her story with us this evening. So, Lisa.
Hold on. Am I on?
Yes, you are.
Oh, there I am. Okay. Hi, all. Okay. Thank you. That was a really good presentation because I had a lot of questions about that. That was really well done. But hi, you guys. This picture up there is if you do need a transplant, you'll be doing this after transplant again. I'll start from the beginning now. So I'm here in Davis, California, and currently I live with my husband and a couple dogs. I have two girls who are now away at college. I had them both after my lamb diagnosis. One was born in 2002 and one was born in 2005. And one's up in Oregon and one's in San Francisco. And my journey with lamb actually began very clearly. It's kind of like, where were you when JFK died? It's like, where were you when your lamb started? And mine was in 1986 in a geology class with 500 other people at the California State University, Hayward. And all of a sudden I had something going on where I couldn't breathe. I started to sweat. I was having trouble taking deep breaths. And I had a friend in class and I was like, I don't know what's going on. So she put me on her back and she carried me across campus to the student health center, where they then told me I had had a pneumothorax on my right side. I'm sorry, the left side at this point. And I'm like, who, a what? What are you talking about? And so anyways, off to the hospital I went, and I was 19 years old at that time. My first pneumothorax, many more. But over the next couple of years, so the first time they just treated it chest tube. I was in the hospital, I think like 10 days, and out I went. Nobody really knew. They're just kind of like, no. Tall, skinny girls have pneumothoraxes, don't worry about it. Which was actually kind of funny because I'm not really tall and I wasn't skinny. So I don't know how they came up with that explanation, but of course, far from lamb being on the table in 1986. So I eventually, on my third collapsed lung on my left side, and the next two happened during summer. The following summer, I had another one. And I was getting ready to go water skiing. And I was like, I feel like someone stuck a knife in my armpit and my back, and I'm like, could this be like what that was? Like, no, that'd be weird. So I told my friends, I'm like, hey, let's go water skiing and then I'll go check it out if it's still there. I obviously didn't make it to water skiing, went in, had another pneumothorax, chest tube, 4 days here, out. Okay. And then I was off water skiing. So no big deal. Okay. Then the following summer, again, getting ready to go hiking. It always happened to be when I was out going to go do something, and I have no idea why, but another one. Okay. Third time. This is not making my life happy at all. I go in, I'm like, what can you do about this? And again, they stuck to the same explanation of, this just happens in tall, skinny girls. I'm like, okay, but why? I mean, nobody could answer this. So at that point, I did get a chemical pleurodesis. So that was 1989. I got a chemical pleurodesis done on the left side. Good to go. Fine. 10 years goes by, and I'm like, well, maybe that was something, and maybe I'll never have a problem again. 10 years goes by, and my husband and I were house hunting. We were moving from San Francisco, moving to Berkeley, looking for a house. And I'm like, something doesn't feel right on my right side. And I'm like, this can't be. I mean, this really couldn't be. So I go in and get the x-ray. Yes, I have a pneumothorax. So they decided at this point it would be lovely to treat me with an outpatient pigtail, because still tall, skinny girls. I'm still getting the same like runaround of why this is. So they put in a pigtail and it drained into a Dixie cup, and I went house hunting. So fixed it. 1 week later, down again. So I'm like, okay, fix it. I had this pleurodesis on my left side. Let's fix it on my right side. I got too much to do. Let's just fix it up. So I had another chemical pleurodesis done. That side was with talc, and both of them worked really well. First time, great. I was all good to go. Then, but on the second time, so this was now the year 2000. So a week apart, I had two quick ones on my right, and I wasn't going to mess around this time. I'm like, I need a pleurodesis. I don't want to live with this like uncertainty of having my lungs collapse at any moment. So I go in to get the chemical pleurodesis, and no discussions with the surgeon whatsoever, but she was brilliant. And she said she decided to take a biopsy at that point because she was going in to do the pleurodesis. And she thought, this young woman shouldn't be having this many pneumothoraxes. This shouldn't be happening to her. So she took a sample, and that sample finally diagnosed my lamb in 2000. And I was feeling a bit short of breath. I knew I couldn't run as far. I couldn't like sprint as much. I couldn't go as fast upstairs, but I was still really functional. And I was having all sorts of tests on like before that, like, oh, you have asthma, or you're just out of shape, all sorts of good excuses. So finally, anyway, she said, no, or it got diagnosed. This is what it is. So then I, of course, went to NIH a few times, got that like head to toe, figured out what this lamb was. And way back then, so in the year 2000, they actually did put me on a lung transplant list because it was the wait list. And so you start off on the bottom. This was even before LAS, and you just accrue time. So I think I like accrued 5 or 6 years before I even got to the top. And then when I got there, I'm like, well, I'm not ready. So they just sort of asked me, but you, at that time, you kept your time on the list in case you wanted to be added back to the list. So, but then in that time, the lung allocation score came out. So I had a pretty low lung allocation score, but I was also very hard to match because I had really high antibodies. I had a 98%, 97, 98% antibody load. So I actually waited under my LAS score. Now with the CAS score, it would have been better, but I had to wait from 2011 when I went back on the list, 2011 to 2014. So I had to wait 3 years for the right donor to come along that matched me with the antibodies. And that was the hardest thing to match. Everything else was fine. There was no other comorbidities. I think it was just general O and pretty just basic, but it was those antibodies. And during that time, it was really hard to maintain oneself, right? When you're on oxygen and you're just doing your activities of daily living, you're using up so many more calories. So I just kept losing weight and losing weight. And they were like, really like telling me, you need to gain weight or we're not going to transplant you. And I almost didn't get transplanted because I had gone in there on my 5'6" frame. I went in as, you know, under 100 pounds. She's like, I don't think you're going to make it. But I'm like, I'll make it. I'll make it. Let's just do this. So here we went. I mean, she was going to do it, but she knew I had to wait a long time. Rockstar surgeon, that was 2014, so 9 years ago, and I've had no antibody issues at all. So the match was well worth waiting for. Because I had 2 pleurodeci, whatever it is. Basically, your lungs have to be detached, from that pleura space. So I had a lot of bleeding. So I was in the hospital about 2.5 weeks because they did pull. They kind of have to, if you don't have to have a pleurodesis now, I don't think they really want you to if you're going to have a transplant. But I had no idea at that point, and I really didn't want the uncertainty of keep having pneumothoraxes. I did still have pneumothoraxes after pleurodesis. And they would just like hang, like you could see the lung just kind of hanging, and it would hurt because it was pulling, but it wasn't deflate, it wouldn't fall all the way, and there was no need for a chest tube. So where was I going with that? So I was in the hospital a little bit longer because of that. Otherwise, it was pretty kind of like everybody else, it's just getting up, it's exercising, it's eating, it's having that first time you got to go to the bathroom after all this surgery, getting the vents out, learning about the bags of medications they bring in, and learning about all your new program and all this. And that was the part that was really mortifying to me, because I was like the person who would just avoid medications. I wouldn't even take an Advil if I didn't have to. And then all of a sudden they brought in these 2 big grocery bags of meds. And nobody really prepared me for that, Actually, I don't think anyone really prepared us mentally for anything. I think our mental health aspect of being prepared for transplant is pretty lacking. You can get a lot of information and you can get all these facts like the CAS score and all this, but we don't get that the mental health, the emotional, the how is it going to react when I had no idea someone was going to bring in all these meds and I had to deal with this. It was so overwhelming. I actually told them to put it in the closet and they stayed there till I think my mom came a couple days later. I'm like, someone's got to go deal with that. And then we had to get them out and organize them. But that, I mean, it was just like way overwhelmed with all of that. But since then, everything's been going pretty good. We have a pretty, at UCSF, we have a pretty good surveillance program that I'm in for life. Once you have a transplant there, you're in their surveillance program for life. And they keep tabs on you. I have to do every month. I have to send in, we do home spiros. We send that in every month. I have to have labs every month. I have to have appointments every 6 months. And then every year you have to have this big testing. There's like an 8.5 by 11 that goes down all these testings from, your eyes to your CT to all your gynecological everything. So we have a really robust surveillance program. And that's just the basic program. Then if you have something come up, such as an infection, a cough, you're not feeling well, you got COVID, whatever, that's in addition to all that. So it's a really good, robust surveillance program. And I feel really confident being in it that they're going to catch anything really early. And so that has allowed me to go out and do the things I love again. And I gotta say, this bike ride here, this picture that you're seeing is a bike ride that I take with another gal who had a lung transplant at UCSF who's 20 years out. And so we ride together and it's amazing. It's a beautiful day every time the two of us go out. So that is my story in a nutshell. And I mean, you can ask me any questions you want if you'd like. And then I know we're going to move into the patient part of the patient discussion. So
yeah, thank you, Lisa. Thank you for sharing your story and your time with us. And I think what you're talking about too really speaks to the importance of our Circle of Hope transplant support program, right? Where we have people that we can pair any women with LAM with that are considering transplant. To have a mentor to walk beside them and kind of help them with these issues, right? You brought up the mental health issue and how difficult that can be. And so it is really helpful to have somebody who's walked that journey to walk alongside of us through that. So thank you for being here. And Lisa will be leading our group session here just in a few minutes. So if you'd like to come and be a part of that and kind of share your thoughts and talk with her more, you have that opportunity. So I do want to acknowledge the 10 courageous women with LAM who actually received a lung transplant this year. We have Karen Kinsey, who got her lungs from Langen, Tamara Beth Fitzgerald from the University of Washington Medical Center, Megan Wiersbicki from Loyola, Cherie Horton at Vanderbilt, and Barb Hare at the University of Washington. We also had 5 other transplant recipients from Loyola, UCSF, St. Joe's Phoenix, Emory, and again, the University of Washington. And the wonderful thing about this is that these women generously donated their tissue for LAM research. So because of that, we had 22 fresh tissue samples, 25 fixed tissue samples, and 4 blood samples that the NDRI was able to procure and help further LAM research. So thank you all so much for that, and congratulations to you. So if you are interested in the Circle of Hope transplant program, this program offers one-on-one guidance, group support, and education to women with LAM who are considering and or actually undergoing the lung transplantation process. We make one-on-one matches based on location, age, interests, needs, and availability. The program also offers educational webinars and support groups. And if you are interested in that, you can register with us at thelamfoundation.org. Go under Find Support and Patient and Family Resources. So I want to thank you all for participating in this evening's Circle of Hope webinar. I hope you found the information helpful to you. Recordings of this and previous webinars can be found on our website at thelambfoundation.org. Give us about a week before we get this one uploaded. There's some things that we have to do to get it to our website, but it will be available. So at this point, we will stop recording.